5, 4, 3, 2, 1. You're live now.
Good morning, good afternoon, and good evening to all of you, and welcome to this webinar, this seminar in the series of big ideas in trauma care. And I welcome you today to the seminar on osteoporotic hip fractures. And I'd like to thank the Asia Pacific Orthopaedic Association for their support. And this is an academic initiative of the Asia Pacific Trauma Society. And we have some terrific speakers today to talk about osteoporotic hip fractures. We have Associate Professor Joyce Koh Bee. She's a senior consultant orthopaedic surgeon in Singapore General Hospital with a subspecialty interest in orthopaedic surgery and trauma service. She specializes in complex trauma of the shoulder and elbow. She's the president of the APOA Research Society. She's also the head of research of the Department of Orthopaedic Surgery at SGH. She has an interest in PROMs, osteoporosis and aging, and health services research, value-driven healthcare. Welcome, Joyce.
Thank you.
We have Professor J.K. Lee. J.K. Lee is a consultant orthopaedic surgeon at the Deputy Medical Director at the Beacon Hospital at Petaling Jaya in Malaysia. He's our president of the Asia Pacific Osteoporosis and Fragility Fracture Society, which is a section of the APOA. He's the president of Fragility Fracture Network, Malaysia. He's the chair of the Asia Pacific South Africa Regional Advisory Committee on the International Osteoporosis Foundation. Welcome, JK.
Hi, everyone.
We also have Professor Rajesh Malhotra. Rajesh is a renowned and very published arthroplasty surgeon in India. He's the chair of orthopaedics at the All India Institute of Medical Sciences and director of the Apex Trauma Center in New Delhi. He's also the past president of the Indian Orthopaedic Association. Welcome, Rajesh.
Thank you. Hi.
We have Sonali Pande. Sonali is the head and senior consultant in JPMC in Brunei. She's actively involved with the Diversity Women's Orthopaedic Group and the APOA Women's Section. She is a council member of the Asia Pacific Osteoporosis and Fragility Fracture Section. And a little known fact about her is she's done a graduate diploma and also a master's of sports science at our university here in Queensland. So welcome, Sonali. And then I will also be speaking to you. And I'm Marinis Pirpiris. I'm the chair of the Asia Pacific Trauma Society. I'm also the president of the Australian Orthopaedic Trauma Society, and I'm the chair of the Cabrini Medical Hospital's Orthopaedic Group. So I'm here to chair this section, and I'm also here to introduce our young moderators today. We have Bedri Karizmailoglu, who's currently working as an assistant professor of orthopaedics and traumatology in Istanbul at the university in Turkey, and he's serving as secretary of the APOA Young Surgeons Forum. Welcome, Bedri.
Hi, everyone.
And we have Science Metadiloglu. She's a young, talented orthopedic surgeon working as a clinical instructor of Orthopaedics Institute at Ledson Hospital in Bangkok, and she specializes in fragility fracture and osteoporosis management and sports medicine. Welcome, Science.
Hi, everybody.
And of course, we have Saraswati Viswanathan. She's a young orthopedic surgeon who practices mainly in trauma and pediatric orthopedics. She's very interested in fragility fractures and identification and treatment of osteoporosis. She's also an accomplished classical singer and plays the Indian classical instrument, the veena. Welcome, Saraswati.
Thank you. Thank you.
And it's my great pleasure now to hand over to Saraswati to start the moderating for this seminar. I hope you all enjoy, and make sure, if you can, to send through your questions so that we may answer them either at the end of the lectures or at the end of the seminar. I hope you enjoy this seminar.
Hi, welcome all of you. Today we have a very interesting seminar on osteoporosis, and what a better way to start off with fracture neck of femur, and what is the role of bisphosphonates? Should we be starting them right away when we see a patient with fracture neck of femur elderly? So this is one question we always have, and we have a very renowned doctor with us, Dr. Joyce Koh Bee, to tell us what her view is about and what the literature says about it. To you, Dr. Joyce.
Thank you. Let me start my slide sharing first.
Sure.
Can everyone see the slide?
Yes.
Okay. Good evening, ladies and gentlemen, fellow colleagues from the Asia Pacific region. First of all, I'd like to start off this talk by expressing my sincere thanks to Marinis and his team from the Asia Pacific Trauma Society for giving me the opportunity to be a part of this very well-organized webinar. I come from the Department of Orthopaedic Surgery of the Singapore General Hospital, who incidentally also celebrate our bicentennial event tonight. That means we are essentially 200 years old, hence you can see the background here. So without much ado, I shall go on to give a piece of what I think about should patients with a fractured neck of femurs be on bisphosphonates prior to discharge. Hip fractures are the second commonest osteoporotic fractures, but technically almost the most disabling. We all know that even as far as a year after the fracture occurs, a high proportion of patients actually do not even recover their pre-morbid, their pre-fall physical function. And hence, randomized trials have already demonstrated that both oral and parenteral bisphosphonate therapy actually reduces subsequent fractures and disabilities. However, the pickup rates of secondary prevention is actually pretty low. Even as late as a decade ago, only 21% of a sample of US Medicare or commercially insured patients actually received effective drug therapy, and low rates of treatment are also being documented in Europe as well as on our side in the Asia Pacific region. So it is somewhat like a lost opportunity. Currently, most hip fracture protocols and guidelines in most countries actually do include secondary prevention in their protocols, and it's a two-pronged approach, including that of osteoporosis treatment pharmacologically as well as falls prevention, and all these to maintain the mobility level of the patients after the fracture in the community. Now, so here comes the point. We said that we are going to have secondary prevention, but let's say in Singapore, we actually capture the fact that bone protection measures should be taken between admission up to 6 months post-admission, which means that technically there is no hard and fast rule about when you should actually start the bone protection measure. That means whether it's within the inpatient admission or how long after the fracture is not really written in stone. So consider this case, for example. This case is essentially what we're talking about. 78-year-old lady with a hemiarthroplasty for neck of femur fractures. Largely, they comprise around 60% of our cohort. And because it's a hemiarthroplasty, all of us here do know that fracture healing is not the concern. Now, let me put this other case to you. This is an intertrochanteric fracture treated by an intramedullary nail. So in this case here, you'll be a little bit more worried about fracture healing. Bisphosphonates actually works by impairing osteoclastic bone resorption in varying ways. But bone resorption in itself plays an important role in normal bone remodeling by removing the poor quality bone to make room for new bone deposition. And hence it affects the consolidation of callus in normal bone healing. So animal evidence have shown in rat models that if you were to start bisphosphonates 1 to 2 weeks after the fracture, you actually have a stronger callus, a greater callus strength compared to if you were to start the bisphosphonate at the time of the fracture itself. So we know that bisphosphonates increase callus formation, but it delays remodeling. But overall, it's not been shown to delay fracture healing. So what's the real-time experience in clinical trials amongst patients? Technically, most trials actually show that whether you start your bisphosphonate 0, 2, 4, or even as far as 6 weeks after the fracture, it essentially does not have any difference between radiological or clinical fracture healing. And this has been shown in hip fracture cohorts, including the Horizon trial for IV bisphosphonates, as well as for oral bisphosphonates. It's also been shown in trials concerning other fractures like proximal humerus or the distal radius. However, only one study by Solomon et al. Showed that there is actually an increased intervention for non-union or proximal humerus fractures after starting bisphosphonates. So the ASBMR Task Force for Secondary Fracture Prevention in their 2019 guidelines actually says that if you are a 65-year-old patient with an osteoporotic low-energy hip fracture, you should not wait for the BMD results, but rather to start your secondary prevention right away within the same setting. And they actually recommend an oral bisphosphonate or actually a parenteral form around 2 weeks after, together with vitamin D and calcium supplementation. So what's the role of us as orthopedic surgeons? Now, it really depends on your setup, whether you are the primary team managing the patient or you actually have a co-management team. All right, and I'll come to that later. And we can still talk about considering between inpatient commencement of therapy versus an outpatient setting. Now, why is that so? Because during the acute phase of hip fracture admissions, there are really quite some barriers to secondary prevention. Besides drug contraindications and drug tolerability, we know that these patients have multi-morbidity. They have so many medical problems. Sometimes you'll end up having to optimize them further for surgery, after surgery. And there's also the problem of polypharmacy. There are lots of medications. There can be potential interactions. And on top of which, this is also the time we are trying to titrate the dosing of various other medications. So it's a really challenging period. Add that to patient and family preferences, as well as the clinical inertia amongst clinicians. And you know that it is actually quite a challenge to start something, simple. Now, in Singapore, some of the bisphosphonates have actually become generic drugs. So cost and insurance is not a concern, but I'm not too sure about in the other countries around our region. Now, what are the contraindications to bisphosphonates? They are not that common, but sometimes patients do have a history of hypersensitivity to bisphosphonates, hypocalcemia, or renal impairment. So these are the three major contraindications to bisphosphonate therapy. But much of what we encounter in the acute period is that of tolerability. For oral bisphosphonates, it's patients with disorders of the esophagus, things like gastroesophageal reflux. During this period, a lot of patients are also prone to stress ulceration, and the majority of them are more sedentary and less able to sit in an upright position unless they are mobilizing quite well. With the intravenous bisphosphonates, patients can get acute phase flu-like symptoms and also hypocalcemia, usually in combination with vitamin D deficiency or overhydration. So these are some of the acute challenges that we can face. So, who to start? The primary care team, which is us, the orthopedic surgeon. Sometimes we actually survive in multidisciplinary team, which is so in my institution. And a lot of the times the geriatricians are the ones who go ahead and start it as long as we are all right with that. In other settings where the patients actually go down to step-down care facilities rather rapidly, the start of the responsibility for starting it may actually be going to the family physician in the primary healthcare setting, who can actually go on to monitor the drug as well. So when and what? Now, it's oral versus injectable. If the patient can tolerate, you can actually start the oral within the acute care setting, that means before discharge. Or you can actually plan to start an injectable bisphosphonate when the patient actually moves down to the community care hospital after the acute hospitalization. In our case, a lot of the patients do go home, so we just sound them out about it, and we actually do start an oral bisphosphonate at outpatient follow-up. Other opportunities to start include primary care as well as the fracture liaison services that actually can follow up on the patient. Now, Zinga et al. Actually identified a few strategies that can help to improve the take-up rates of secondary prevention as well as to ensure compliance. And the first is actually education of the patient as well as the caregiver. They must be informed about the nature of osteoporosis itself and their risk of a second fracture. Communication to the primary care team is actually important. So the patient should be given the notes to actually speak to their primary care doctors, plus or minus the DEXA scan results. The third is to formulate an actual treatment plan for the patient based on the local institution or the country's protocol and communicate it to them. And last but not least, I think fracture liaison services, and JK will probably agree with me, is all important in the country setup, so much so that they can actually follow up with the patient with monthly calls and on follow up on their treatment. So this is our patient here, the same patient after 3.5 years. All right. So this is where I'm also trying to illustrate another point. Much of what we talk about commencing treatment, all the time, I'm also a little bit worried about the follow-up of the patient. There should be follow-up in terms of for development of long-term issues such as osteonecrosis of the jaw. The dentist should be made aware that the patient is actually on a bisphosphonate. Things of atypical femur fractures. The primary care doctor by then may be the person actually initiating the drug holidays or even conversion to other anti-osteoporotic agents. There are other therapeutic options besides bisphosphonate, which actually do give a reasonable compliance, and that includes the rank ligand inhibitor denosumab, which is a 6-monthly injections, pretty well tolerated. The local site responses are generally well tolerated, and the thing is that this drug can be used in renal impaired patients. Now, new paradigms have actually evolved in the treatment of osteoporosis, including in secondary prevention, and it's really this concept of sequential treatment. That is essentially the use of anabolic agents to build up your bone stock rapidly in patients presenting with very poor BMD for early secondary fracture prevention. So you want to raise the bone stock rapidly so that you prevent the next fracture early. And then this is followed by an anti-resorptive therapy to maintain the bone stock. Currently available anabolic agents include teriparatides or the very new anti-sclerotin monoclonal antibody, romosozumab. And all this is largely dependent on patient selection, cost and tolerability, as well as taking into consideration risk-benefit ratios in multi-morbidity patients. Some drugs do have a little bit of a cardiovascular signal, so we do have to be cautious in this multi-morbid group of patients. So in conclusion, osteoporosis treatment must be commenced after hip fractures, but the timing of the BP does not really impact clinical and radiological fracture healing. And much of the things that concern us are really medical and logistical concerns. Now, oral BPs can be started in patients, but more often after discharge in a structured care protocol where you actually follow up your patients. Of course, other options that increase that have a potential to improve compliance include injectable agents at 2 weeks post, patient and caregiver education, as well as the setup of an effective fracture liaison service. Thank you for your attention.
So it was wonderful, Dr. Joyce. You have concised the importance of bisphosphonate, when to start, how to start very nicely. There are a few questions that have from the audience. One is, what is the difference? Why do we have to start it by 2 weeks itself instead of 12 weeks after the fracture, where the efficacy has not shown much of a difference? Can we start it at the end of 12 weeks than just immediately 2 weeks later. That's one part. Second is, should we not be worried about atypical fractures in, when we femoral fractures when we administer bisphosphonates?
Okay, let me take on the first question. So I probably covered a little bit of that. So there are a lot of people who think that why not we just treat the fracture, let the patient settle down first, and then you start it. It probably is not really a big deal starting it a little later, unless your patient actually has a very low bone mineral density and you really want to arrest, the low bone mass very quickly. However, the issue is actually more of the problem of compliance. A lot of the time, by 12 weeks, your patients don't even come to hospital, or they have been followed up by someone who actually is not, really conversant with this issue. And that's the reason why education and communication with the primary care facilities is actually really important. You actually can start them at around 12 weeks if they are more settled and they're happy, but make sure you don't forget to start it. That's where the fracture liaison service actually comes in important to you in case, the patient doesn't turn up, and in case, you lose track of the patient. Now, for the second question, the AFF, it is a real problem. So I think one of the issues of AFF is that it does, the first 10 years, it does scare people away from starting bisphosphonate therapy. But overall, I still think bisphosphonate is a very useful primary agent for treating age-related osteoporosis. Now, the problem is that for some subgroup of patients, sometimes you'll see in their clinical notes, they are actually like 7 years and 10 years on it. And, people have not converted to other agents or even considered giving them a drug holiday. This is where it is a little bit scary, and that's why you actually do need a source of monitoring for the patient. The only issue is how are you going to effect that in your own healthcare system?
Yeah, right. We have a question from Dr. Rajesh for you. If the patient is on bisphosphonate and then sustains a fracture, do you stop bisphosphonate for the time being, and then when do you continue?
That means you're talking about sustaining an osteoporotic hip fracture, not an atypical fracture.
We're talking about a fracture per se. It could be osteoporosis. Generally, we are starting bisphosphonate in an osteoporotic patient. It could be atypical fracture or some other fracture. If patient sustains another fracture during bisphosphonate therapy, do you stop it, or what is your?
Okay, so
especially on the oral one, because injectable I think is once a year.
So basically, I will answer this in two parts. So the first scenario is patient is actually on bisphosphonate and actually still sustains an osteoporotic hip fracture or any other osteoporotic fracture. In this case here, usually people do consider conversion to another agent, sometimes an anabolic agent, because there's a chance that the bisphosphonate is not effective enough for pulling up the patient's bone mineral density to a more ideal level. So generally, you consider a switch. Now, if the patient is on bisphosphonate and sustains an atypical femur fracture, most studies have shown that you should actually stop bisphosphonate. But whether you convert to another agent or not is really a point of contention. Studies have not shown Fortier to be more effective in preventing further atypical fractures, but a lot of studies have shown that the cessation of the bisphosphonate with atypical fractures actually is the one that significantly reduces the onset of another second atypical fracture, or actually slows the healing of the atypical fracture. That's what a lot of the radiological studies have found, right? So you have to stop it, but then it's something like taking a drug holiday. However, you may have to consider recommencement on another alternative agent. But your problem is that a lot of the agents, even agents like the denosumab, have a minor risk of atypical fractures in the presence of a prior bisphosphonate therapy, especially if it has occurred before.
Yeah, thank you. I have one more question. When do you start teriparatide? Do you start teriparatide in certain cases where you think the bone is severely osteoporotic? And if you want to start off, what is the ideal duration? I mean, when do you start after the fracture fixation or after the hemi?
Well, actually, I think teriparatide can be started quite soon after fracture fixation if you want to start it. It's an anabolic agent, so it should be fine. The only thing to be careful about teriparatide is actually, you have to track the PTH level of the patient. And at the same time, actually the take-up rate can actually be quite poor because they are daily subcutaneous injections. So a lot of patients are really, really not that into it. Ideal duration is the recommended duration is around 18 months. But most of the time I find that the endocrinologists actually keep the patients on for, let's say, around 12 months before they convert them to another agent.
Thank you for the answer. And I think we're running out of the time. We'll go to the next speaker. Thank you for giving us an idea about the oral medication, especially the bisphosphonates in the fracture. Now we move on to a very important topic. Why do we consider this as an emergency? An elderly fracture, a fracture, osteoporotic fracture. Why do we consider it as a surgical emergency? We have Dr. Rajesh Malhotra from AIIMS to tell us about it. To you, sir.
Thank you very much. Like our chairperson said, good morning, good afternoon, good evening to everybody. And I'm going to speak about why elderly osteoporotic patients with fractured neck of femur are an emergency. Now, the fractured neck femur is a telltale sign of a weak bone that failed in a weak patient who fell. And what is to be done? Because here was a patient who was walking and is suddenly bedridden. The treatment is surgery. And when is either on the same day or the next day. So why an emergency? An emergency because if you deal it as an emergency, you aim to decrease the morbidity and mortality. There are 28 prospective studies, including this systemic reviews and meta-analysis, which studied more than 31,200 patients. And the patients who were operated within 48 hours had a 20% lower risk of dying within 1 year. In this JAMA network paper, association between wait time and 30-day mortality in adults undergoing hip fracture surgery, it studied more than 42,000 patients and found that increased wait time was associated with a greater risk of 30-day mortality and other complications. And 24 hours may represent a threshold defining the higher risk. Paper on early mortality after hip fracture, is the delay important? Delay important, mortality associated with delay, observational study. Another paper from a multi-center survey, causes and effects of surgical delay in patients with hip fracture, a cohort study. Every study has reached the same conclusion that emergent surgery decreases mortality. Why is it so? Why is it so important to operate? What happens with delay is a bed sore, deep vein thrombosis, pneumonia, delirium, and malnutrition. So the delay leads to immobilization, immobilization leads to complications, and complications lead to mortality. Now, we know for all practical purposes, the hip fracture includes the hip and pertrochanteric fracture. They have somewhat similar profiles, though pertrochanteric patients are somewhat older and generally somewhat more morbid. Fall itself is an ominous sign, and it often suggests a failing physiology because the old person who fell could be having orthostatic hypotension, hypoglycemia, poor reflex, weak muscles, and of course, an MI or a stroke or a syncope. And the fracture is considered to be a systemic disease by many people, because the fracture leads to excessive pain, which leads to poor intake. The pain disturbs the whole physiology of the patient. It stresses the patient. There's tachypnea, there's tachycardia. The patient is immobilized, leads to inflammation, can lead to electrolyte abnormalities and poor respiratory effort. So the goal is to put the patient back on the feet before the patient realizes that there's anything wrong with him or her. And that is why the early surgery is important. Any role of conservative treatment? Absolutely not. It's obsolete. It's only for severely ill patients where giving them anesthesia or operating them would amount to a very high risk of losing them on the table. It's often anyway practiced in developing world because of financial constraint or lack of infrastructure, where the patient is left to the mercy of the fate. The surgery is the main treatment modality. Arthroplasty is preferred in elderly. You just saw a beautiful example. I always believe that a patient who had one hip fracture and comes to you with another fracture is somewhere there has been a lack of proper supervision and proper treatment, whether it's an osteoporotic fracture or an atypical fracture. But an arthroplasty in an elderly, or any treatment for that matter, must allow full weight bearing, early mobilization. You can't expect an old person to walk non-weight bearing or partial weight bearing. And then arthroplasty does have predictable outcomes. So the patient should be put back on his or her feet as early as possible. So the guidelines for that, according to American Association of Orthopedic Surgeons, is 48 hours. And as per NICE guidelines, it's 36 hours. Can we achieve this? Well, if you are in USA, yes, 78%, 70% in different studies. Whereas in North Korea, 19% received surgeries within 3 days. And in Japan, 23% received surgery in 2 days. So you can appreciate that the time to surgery has wide variation globally. And this is a paper published from our own center where we studied the factors associated with delayed surgery in elderly hip fractures in India. And we found that only about 1/3 of the patients received surgery within 48 hours of reaching the hospital. And about 20% of the patients presented to hospital after 24 hours of injury. And delayed surgery was primarily due to medical comorbidity. So we'll have more of that. So it's much more, the cause is much more frequently medical reasons for delay, but then administrative reasons do also play a role. So in this study, when the time from hospital to surgery was 48 hours or more, you can see that in more than 50% cases, it was because the patient was medically unfit. And then you see the breakup of cardiac pathology, pulmonary pathology, uncontrolled sugars, uncontrolled hypertension, anemia, and multiple issues. Then, of course, unavailability of operating room did contribute to about 10%. It's out-of-pocket expense in India for most patients to arrange money, misdiagnosis, and to arrange special implants. You can see the most important reason which precludes early surgery in these patients is that they are medically unfit. Factors associated with delayed surgery also include delayed presentation when the patient reached hospital more than 24 hours after the injury, which was sometimes because the relatives thought that it was not urgent, urgent care in hospital was not necessary immediately. The patient was admitted to a previous hospital where care was delayed, patient preference to get transferred from outside, or difficulty in arranging the transport. Some of these factors may be absolutely alien to the people in the well-developed healthcare system, but unfortunately that does happen in some of the developing countries. Now, are the faster surgeries worth it? Most of the large database studies favor early surgery, even though they don't answer if the poor outcome with delay is due to the reason for delay, that is medical illness per se, or because of the delay in operating them. So in this landmark study published in Lancet, from Mohit Bhandari's group, we were one of the centers out of the 17 countries, the accelerated hip surgery versus standard care in hip fracture, the hip attack surgery. So the patients with hip fracture that required surgery were included if they're 45 years or older. 1:1 randomization for accelerated study when wanted to operate within 6 hours versus standard care. So there were 1,487 patients in accelerated group versus 1,483 in standard. The median time to surgery in the first group was 6 hours, 24 hours in the standard, and 90-day mortality was comparable. There was no difference. So the accelerated surgery did not significantly lower the risk of mortality or a composite of major complications compared with the standard care. Now, there was something which also came out of this study, which said that the accelerated surgery did show lower rates of strokes, lower risk of delirium, lower risks of infection or UTI, faster mobilization, and lower length of stay. But they were secondary outcomes. The primary outcome of mortality did not differ between the two groups. So then why the discrepancy between the hip attack and other studies? It's because even in the standard care, the median time to surgery was 24 hours, which is ideal. That's according to several guidelines, it's actually almost ideal. And second thing is that not all patients may benefit from accelerated care, and we'll talk about it a little more. So if you look at the patient spectrum, the healthy patients they are the ones where delay has little impact. They are fit for surgery immediately, but the delay won't matter.
Can you see the WhatsApp? Can you see the chat that I'm writing on the questions? Okay, good. So though you have to do this now. Thank you.
So the frail patients which have medical conditions which increase surgical risk, there is the dilemma whether to wait for optimization or not. But the critical patients who are terminally ill with low life expectancy, the risk of surgery outweigh benefits, and possibly these are the patients who are best left alone without surgery. So when you have a frail patient, if you optimize and operate, the advantage is decreased surgical risk. Disadvantage is delay in surgery, and the patient may not be optimized and may continue to deteriorate. If you operate early on them, you have the advantage of better optimization after surgery and no delay, but disadvantage is there's an increased risk from surgery and there could be a second hit. Now, second hit is something which is a familiar concept in polytrauma, because in surgery, there's a risk of inflammatory markers and there's an added stress. So is it applicable to hip fracture, and does it favor the delayed surgery? Now, this is a study which looked at the cytokines and C-reactive protein production in hip fracture operated elderly patients. And you can see that there is a rise in the markers at 48 to 60 hours. And then those who are operated, they show higher levels of marker. So there is an increased inflammatory response with surgery, although the significance is still not established. So is it safe to operate on those with acute conditions, or will it cause a double strike? So operating on patients with acute medical conditions in the hip attack showed that the conditions such as congestive heart failure, atrial fibrillation, MI, severe electrolyte imbalance, and all, stroke, DVT, P, mechanical ventilation, infection, active cancer showed no increase in mortality with accelerated surgery. So it is safe to operate on these patients. It's a very important message coming out of this paper. The pre-operative optimization is to identify and treat the correctable comorbidities like anemia, anticoagulation, volume depletion, electrolyte imbalance, uncontrolled diabetes, uncontrolled heart failure, correctable cardiac arrhythmia or ischemia, acute chest infection, and exacerbation of chronic chest condition. You should attempt to optimize them. Now, what is ideal? Ideal is whatever these comorbidities are, they are fully corrected. Now, reality is that it is not possible to achieve full correction, which takes a long time, and aggressive correction may be detrimental. So it's possibly good to accept even suboptimal correction and do an early surgery. So there's a window period to operate. After fracture, there's a deranged physiology, and that can lead to the onset of SIRS and MODS and leading to morbidity and mortality. And we must try to prevent this. And the solution is to have early definitive care so that the elderly patient can be in the pre-injury state. Many comorbidities in hip fracture are chronic, and waiting for optimization in these cases may lose time, and it is often unsuccessful to optimize, and there are unclear benefits. For example, whether you transfuse before the surgery, during the surgery, or after surgery, it does not impact the outcome. So if the patient has anemia, don't have to transfuse and wait to optimize. Similarly, the chronic hyponatremia associated with high mortality, but not acute. So if there's acute hyponatremia, you can actually have suboptimal correction, but start operating and try to get the patient on the feet. A very unique condition is delirium in hip fracture. It's very common, often underdiagnosed. It's often the first manifestation of a worsening health in elderly, may occur after or before surgery. It results in delayed surgery because the underlying cause may not always be present, and it leads to a vicious cycle. So when you have delirium, it leads to poor respiratory effort, then ventilation, difficulty in weaning, and leads to the sepsis, VAP or MODS, further aggravating delirium, and the surgery is delayed. And the delayed surgery itself leads to delirium. So it has been shown that it is different from the delirium of medical illness. The spontaneous resolution at the time of discharge may occur without correction of any known cause. So implication is that in hip fracture, delirium, the hip fracture itself is an illness, and not just a fracture, which needs treatment, and that itself addresses many patients who are having delirium rather than specifically trying to optimize and treat it before the surgery. Avoid unnecessary investigation. There have been studies which have shown that the preoperative transthoracic echocardiography has no effect on mortality and surgical timing. There's absolutely no need, but it can delay the surgical treatment. and there's a longer length of stay, and there often results in no cardiac intervention whatsoever. This is the data from our center. The patients with medically fit did not have a increase in mortality with delay, but it's medically unfit patients who actually get higher mortality if the surgery is delayed. So to summarize, hip fracture in elderly can tilt their already compromised health to an uncompensated state. There is a need for regional guidelines regarding timing of the surgery. Aggressive optimization may not be ideal. Emergent surgery may prevent deterioration of patient rather than waiting for correction of acute condition. Further research is needed to know how often optimization is successful and if it improves the outcome. I take this opportunity to invite all of you to Current Concepts in Arthroplasty Conference being held at All India Institute of Medical Sciences, New Delhi, India on 30th and 31st October. It is preceded by a cadaver course on direct anterior approach for hip replacement on 29th of October. I thank you all for a very patient listening.
Thank you for your wonderful presentation, Dr. Rajesh. There's some of questions from the audience. First is if the patient was on biphosphonates and then they have the neck fractures, without need to stop biphosphonate after hip replacement, or should be continued just like that?
So there is absolutely no need, especially for a fractured neck femur where we have done a replacement. There is no need to discontinue. Like the previous speaker said, some people may think that it signifies a failure of the anti-osteoporotic treatment. However, while that is true, or may be true, I think one must realize that no anti-osteoporotic treatment is 100% efficacious. And even the anabolic therapy reduces the risk of fracture by 65%, which means that 35% patients may still have fracture. So I'll not be in a hurry to stop it. I would like to continue it or give an alternate form of osteoporosis treatment, but treatment for osteoporosis has to be given.
And the second question, what is your recommended protocol for pain management of elderly patients till the time to go to under surgery?
Yeah, actually, I have said that about the pain. The pain is a big, as it elicits a lot of stress. It leads to altered physiology. It leads to tachycardia. It leads to tachypnea. It's also inhuman to let a patient suffer. So one of the earliest things to be done for a patient with hip fracture who reports in ED is to give him pain relief, which is best done by fascia iliaca block. So in our tertiary care center, the level 1 trauma center, the nurses have been trained to give fascia iliaca block. So while the IV line is being set in, the samples are being taken before radiology. It is a protocol to give fascia iliaca block to the patient, or at the same time also give perfalgan or paracetamol infusion before even shifting the patient to X-ray, because you don't want the patient to be in pain.
Mm-hmm. And the last question, in your practice for fractured neck or femur, do you prefer modular bipolar replacement or total hip replacement?
So that's a great question. Right. I think the answer depends on the physiology of the patient. If the patient is physiologically young, I would do a total hip replacement, and I would even do a dual mobility cup, because we know that the total hip replacement in fractured neck femur has got higher incidence of dislocation, because these patients don't have previous pathology in the hip joint capsule. The capsule is lax, tissues are lax, and there is a high risk of dislocation. So my preference is for the dual mobility cup. When you are doing a bipolar, it's actually doing the same thing, because there also you are giving a large head. But if I have to do a hemi replacement, I'll do a modular hemi replacement, because in case the patient starts developing acetabular problem later on, we can knock off the bipolar cup and put in an acetabular cup and convert it to a total hip replacement.
Thank you. So because of we have a limited time, so let's move to the next topic that is quite common topic that maybe some is going to be the obstacle of quick or early surgery for neck or femur. The topic is about should Coagulation Therapy, Delay Surgical Management in Patients with Fractured Neck of Femur, by Dr. Sonali Pande. She is a consultant of orthopedic and sport injury in Jerudong Park Medical Center in Brunei. Welcome, Dr. Sonali.
Thank you, Sans. At the outset, let me thank Marinis and Jamal for giving me opportunity to talk on such an important topic. I bring you all greetings from Abode of Peace, Brunei, where I'm working for last 15 years. Over next 15 minutes, I will try to cover this topic under this subheadings. And it's time to look at the basic stuff we learned in medical school about coagulation cascade. As you can see in this complex figure, we are aware about the intrinsic and extrinsic pathways which generate series of reaction in which inactive circulating enzymes and their cofactors are activated. Number of anticoagulant agents are depicted here in the color. You can see the most commonly being used, the vitamin K antagonist. Warfarins are seen to act at multiple levels to achieve thrombogenesis or rather inhibit thrombogenesis. As per the administration of the anticoagulants, they are divided as parenteral and oral anticoagulants. When we talk about the antiplatelet agents, the aspirin are known to inhibit the platelet aggregation, while the clopidogrel are working at inhibition of the platelet adhesion at the injury site. We are all aware about this picture which depicts the epidemic of hip fractures, which is going to be projected the highest incidence in the Southeast Asia. All the elderly patients with hip fractures are with polypharmacy, and they have fragility fracture, and this in turn is going to give a huge burden on our health sector. All the patients with hip fractures for their comorbidities are on number of anticoagulants. The data from Australia suggests that 50% of these patients are on antithrombotics and up to 10% could be on anticoagulants. From various countries, we have statistics showing the similar incidence, and we are now seeing increasing prescriptions in direct oral anticoagulants, DOACs, especially from US. Our data from Brunei also shows 30% comorbidities in the hip neck of femur fractures. And most of these patients were on anticoagulants, aspirin and warfarin and clopidogrel still being the major prescribing anticoagulant. We are seeing increasing incidence of use of DOACs from the cardiologist. We know that the timing of hip surgery is very important in playing the role at reducing the morbidity and mortality. We have heard it from earlier lecture on the same. And we are aware that within 48 hours, if the patient is operated, there is significant low risk of mortality and complication. These contemporary guidelines for surgery within the golden period of 48 hours come at a compromise when the patient is already on anticoagulant because of the associated comorbidities. This is in turn associated with increasing time to surgery. In this particular paper, one can see that there is 7 times increased probability of delaying the surgery, which in turn increases the financial burden almost 10 times. There's also 3.5 times probability of having minor complication in such situation. This is an interesting article which looked at the hip fracture patients with pre-existing cardiovascular disease. They were divided into 3 subgroups as to be taking anticoagulants, antiplatelet, and no medication. The group with the anticoagulants was seen to have increased rate of surgical delay and short-term mortality. Hence, it is very important to have appropriate perioperative evaluation and management. So how does this matter to us clinician? As a surgeon, I would like to operate the patient as soon as possible and alter the length of stay in the hospital. Also, I would like to know about the blood loss and need of blood transfusion. As surgeon, we really like to know the effect of anticoagulant reversal on surgical hemostasis. Anesthetists are worried about what type of anesthesia they can give, and also that they have to be prepared for any post-anesthetic complications like spinal hematoma. All of us are worried about the perioperative and post-operative events, and we aim to reduce the mortality in this group of patients who already have pre-existing cardiovascular disease in majority of the situations. There are indeed some gaps in the management of the anticoagulated hip fractures, as there is no standard approach. There is striking absence of generally adopted guidelines in orthopedic literature. Hence, we have to rely on protocols from other associations like cardiac and anesthetic societies. For example, NICE guideline give no recommendations on anticoagulants in neck of femur fractures. The American Academy CPG is limited to its recommendations to just aspirin and clopidogrel. BOA standard of trauma living document does give some recommendations on the thromboembolic prophylaxis, but fails to address the anticoagulation in complex surgeries. Let's look at different anticoagulant agents and their clinical implication. Antiplatelet therapy, if it is prescribed as a single medication, then there is no contraindication for spinal anesthesia. However, if there is a dual platelet therapy prescribed to the patient, it is best to favor the general anesthetic on a risk-benefit basis. All high-risk patients should be monitored for signs of vertebral canal hematoma. Warfarin are still the most commonly used VKAs. If patient is on warfarin, that needs to be stopped on admission, and reversal can be started right from AE. The goal is to reach INR of 1.5 or lower before proceeding for the surgery. Some of the centers are preferring to give prothrombin concentrate depending on the availability. This is an interesting graph from Australia, which shows increasing trending of use of DOCs in patients on admission for hip fracture. This is obviously after the FDA approval of dabigatran in 2010, which is used for a number of indications as highlighted here. DOCs are the emerging favorites in the anticoagulant group because of their ease of use and minimal need of monitoring. There are of two types, thrombin and factor 10 inhibitors. However, there is hardly any evidence on the surgical timing. Standard coagulation screens are very difficult or unreliable in monitoring their effects. Thrombin time is the most sensitive, but only for dabigatran. It's also important to know that they need specific reversal agents, which could be quite expensive and not available easily, and therefore limited for life-threatening situation. DOCs are eliminated depending on the renal function of the patient, and this in turn affects the half-life. This is very important guide for surgical and anesthetic timing. And in general, consensus is to wait for 2 half-lives. So if patient is on dabigatran, it's best to plan surgery 30 hours after the last dose of medication. However, post-operatively, it is pretty safe to restart the DOCs within 12 to 24 hours. Next few slides, I'm going to review the literature, especially in the last couple of years. And I've tried to categorize according to the different anticoagulants. So if we look at warfarin or the vitamin K antagonist, both these papers show no significant association of reversal of agents on mortality. Similar finding is seen in this paper, and when reversal was questioned, it was noted that reversal and delaying the surgery for the same is not really necessary. In fact, reversal is known to increase the length of stay in the hospital significantly for this patient. When we look at the second group, which is antiplatelet drugs, this meta-analysis systemic review covering about 5,000 patients shows that there can be increased transfusion rate in antiplatelet group. However, it is important to note that there is no need for delay of surgery, and the paper concludes that early surgery can significantly reduce mortality and hospital stay. Moving on to the DOACs, there are not many papers coming out in last few years on DOACs. This particular review of hip registry from Sydney, looking at about 3,000 over patients, shows that 1/3 of the patients had surgical delay. However, timing of surgery did not affect the mortality, and serious adverse effects or transfusion problems were noted. This is supported by study from Brisbane. It is interesting to note that the time to surgery was as long as 35 to 66 hours, especially because of patient being on DOACs. And when they looked at early versus late surgery, there was no significant perioperative hemoglobin level or need of transfusion or even post-anesthetic complication. So both this paper recommend no reason to delay the surgery. Worldwide, most of the papers on DOACs are supporting that the expedited surgery within 48 hours seems to be the golden standard and appears to be safe. I would like to draw your attention to this recent meta-analysis from CanVector Group. This is covering 34 studies. Over 40,000 patients have been assessed. And it was noted that time to surgery was delayed by over 13 hours. And there was threefold higher odds of having surgery beyond the recommended 48 hours from admission. In-hospital mortality was also noted to be higher in patients on DOACs. They have strongly recommended evaluating the accelerated surgery protocols and role of rapid reversal of anticoagulants in neck of femurs with anticoagulants. So if we try to look at the current available guidelines, in Brunei, we have perioperative guidelines from Anesthesia Society. However, it is not updated and needs revision. This particular paper in effort talks about the pragmatic approach towards the management of anticoagulation in hip fractures. So if you focus on the central two columns, which are antiplatelets, if the patient is on aspirin alone or a single drug, then it is fairly comfortable to continue the medication. No bridging is required and patient can proceed with the surgery. If patient is on dual medication, again, same protocol can be adopted. However, it is very important to note that for uncontrolled bleeding, one needs to be prepared for a platelet transfusion. Moving on to the DOAC group, if patients are on DOACs, one needs to omit DOAC, and depending on the half-life of the drug or the renal function of the patient, we can plan surgery either 24 or 30 hours from the last dose. There is no need of bridging therapy. However, it is very important that in this group, we involve multidisciplinary people. Moving on to the vitamin K antagonist group, it is important to do risk stratification and divide the group as low risk or high risk. If the patient is a low risk, then we are always aiming for INR to be achieved less than 1.5 or 1.5 with the help of vitamin K injection, and one can then proceed for the surgery. However, if we are facing a high-risk patient, then there is a need for bridging therapy. Bridging therapy is a temporary anticoagulation level which we are achieving in a patient who could be having problems like multiple PEs, mechanical heart valve, or recent stroke or thromboembolic disorder. Some centers where prothrombin complex is available, it is used for complex or resistant reversal, or even for correcting short interval when correction in short interval is needed, like in young patients with neck of femur. However, one needs to watch for severe allergic reaction or thromboembolic events. Anesthesia Association of Great Britain and Ireland have come out with these guidelines, which have been recently modified. These form the basis of most of the CPGs and are the gold standard currently. In fact, they have come out with a comprehensive printable chart, which is recommended to be displayed in AE and ORs for all the team members to know. And they are very specific about individual drug and how the patient should be managed and what kind of anesthetic management can be planned. This forms also the basis of the chapter, which has been published as a preoperative medical assessment in the recent orthogeriatric book. Also, Fragility Fracture Network recognizes this particular protocol and forms the clinical toolkit. So if I go back to the question that we wanted to answer, should anticoagulation therapy delay the surgical management in patient with fracture neck of femur. From all of that we have seen, the recent evidence and discussion, I think the answer should be firm no. We know that the antiplatelets and vitamin K antagonist guidelines are pretty clear. DOACs, which are the near anticoagulants, we can easily perform surgery in a safe zone. Time to surgery can be lowered to 24 hours depending on the renal function. Anticoagulants can be restarted within 24 hours without any bridging. There is, however, need for low-risk, accessible, specific reversal agents. Perioperative optimization of hip fractures on anticoagulants require meticulous balancing of risks, especially with surgical delay and intraoperative hemostasis. There is no doubt that we need to involve multiple specialty people. Orthogeriatric role is quite established in this. We need to establish hospital-specific guidelines till standard international guidelines are established. And this domain continues to be of great concern for both clinicians and researchers, and we have to watch for this space. Thank you for your attention.
Thank you, Dr. Sonali, for your great talk and presentation. I'm sure everybody was really interested in because it's a problem that we face every day. So we have a couple of minutes for the questions. I know you already replied some of those questions, but maybe this will be a chance to also to stress out them again. So the first question is, what is your opinion about using dabigatran in the elderly?
Like we've already seen, this is something increasing trend because of ease of use and ease of monitoring. If the patient is having normal renal function, then we know that the half-life is going to be pretty standard, which is going to be about 15 hours. And then we are safe to start or plan surgery for about after about 30 hours for such patient. A challenging part is how to monitor patients on dabigatran, and only prothrombin time is a sensitive indicator. So we have to be mindful about that. And in acute situation or when we are in urgent need, we do have reversal agents. However, it has to be available. Some of the studies have highlighted that the use of reversal agents should be encouraged because the length of stay in such cases can actually be financially more burden. So I think as long as we are aware about the drawbacks of the newer DOACs, we are pretty safe to go ahead with surgery in elderly.
Okay. The second one is not reversing anticoagulants for geriatric hip fractures is not associated with increased volume of blood loss or transfusions when compared to those reversed. So why should we reverse?
In fact, that's something which has been questioned in most of the recent literature, especially the last meta-analysis that I shared with you. The Canvector group is working on the same hypothesis about whether there is really need of reversal. At the moment, that is not being established, and we don't have standardized international recommendations on that. So it is always important that we keep these guidelines parallel to what is the local multidisciplinary hospital protocol. And that is the biggest challenge that we are facing currently. Till the international protocols are out, I think we have to run both of these parallel, the Great Britain Anesthesia Society protocol, and run it parallel along with your own hospital settings, because many places the anticoagulant choices are different. The reversal agent availability is a problem.
Okay, thank you. The third question is, when is reversal of anticoagulation indicated after surgery?
After surgery, usually we are not looking at reversing. In fact, we are looking at restoring the anticoagulation state. So it is pretty, sorry?
Probably they meant that way. I mean, the restoring the anticoagulation.
That's right. I think it is pretty clear now that we can start the anticoagulant agents within 24 hours. So it really depends on what anticoagulant agents we had. If it's a high-risk patient, it's important to achieve the bridging with heparin till we are ready to get the INR up at 2.5 therapeutic level.
And the last question will be, should we use bridging anticoagulation with low molecular weight heparin in patients whom long-acting ones are stopped for surgery?
Depends on the, again, risk of patients. As I mentioned earlier, if the patient is a high risk, then maybe your orthogeriatrician or cardiologist will prefer to keep patient on heparin.
Okay. Thank you again for your presentation and detailed information you provided us. And I just want to move to the next lecture. I have the pleasure to introduce Dr. Joon Kong Lee. He will be telling us about does frailty affect outcome in patients with insufficiency fractures. So I will just leave the floor to Dr. JK. Thank you.
I'm trying to look for my file now. Sorry for that, some technical glitch here. Okay. Yeah. Can you see my slides now, ladies and gentlemen?
Yeah, it's perfect.
Yes.
Great. Sorry for the technical glitch. And good evening, ladies and gentlemen, friends and colleagues. And thanks a lot, Dr. Jamal and Dr. Marinis, for the invitation. It is really my great honor to be able to share my limited experience with all of you here. And my duty today is to talk about this topic. Does frailty affect outcome in patients with hip fractures? These are my disclosures. We have seen patients at 80, 90 years old come with hip fractures, not maybe the first time, even the second hip fracture when they come in. And when you get close to the patient and relative, the patient can be very emotional with the surgeon in charge. You spend time with them. And the common question that my patient asks me is, Doc, will I be able to leave the hospital alive? Because they realize that at 80, 90 years old, hip fracture is a high-risk fractures. And they know that most of the time they need surgery. And they worry about the risk of surgery and they worry about the risk of anesthesia. Why? Because at this age now, they have all different medical problems and they know that I'm a very frail old person. Will I survive or not? So we have to understand that we handled an older person, like very old, with the hip fractures. And this group of geriatric patients, they have very unique vulnerability. And many times they already present to you that the current sort of so-called disability in terms of physical disability and also functional disability. Many of them have heart problem, lung problem, hypertension, diabetes, renal failure, and all this comorbidity. And all this actually push them down even further physically, medically. They become unfit and all they call themselves frail and old. Frailty is actually a multi-dimensional geriatric syndrome. It's not the simple word you are old. It is a multi-dimensional geriatric syndrome characterized by a cumulative decline in the multiple body system and function, and with the pathogenesis involving the physical as well as the social dimensions. And it increases the vulnerability to poor health outcome, such as disability, hospital admission, reduced quality of life, and even death. There are many ways to assess frailty, and one of the most complicated one is called comprehensive geriatric assessment, which is actually not yet applied for geriatric patients, the hip fractures and so on. It also can be applied for other group of patients like palliative care, patients with cancers, and all the other medical problems. Back home in Malaysia, with the recent publication of the position statement of fall and fragile fractures by Malaysian Society of Geriatric Medicine, we were actually given the option and even encouraged to use something more simple, something called Frail Scale, which is actually stand for fatigue, resistance, ambulation, illnesses, and loss of weight. And this is simple and can be rapidly administered by any healthcare workers, by the patient themselves, even the family and the carers. And the Frail Scale can be repeated frequently and allows detection of frailty at an early stage. This is the Frail Scale that we talk about. It's much more simple. You look at the comprehensive geriatric assessment that is really long and appear very complicated, particularly for orthopedic surgeons who have more simple mind and also our simple thinking, compared with a physician or anesthesiologist. The Frail Scale, as I say, fatigue. Are you fatigued? Resistance. Are you unable to climb the flight of stairs? Aerobic aspect. Are you unable to walk a block? The illnesses, do you have more than 5 illnesses? And loss of weight, have you lost more than 5% weight in 6 months? You're considered pre-fail if 1 or 2 positive answers are given, and you're considered frail with 3 or more positive answers. So, I would like to ask all the audience for tonight's symposium here or webinar here, are you frail? Now, let's share some papers with you about the frailty and how it actually have impact on the outcome of hip fracture surgery in the older people. And this paper actually from Ramesh Kandel from Nepal, and it's actually look at 100 older patients of age 60 now and above, and those who have undergone hip fracture surgery. And this particular study actually used Frail Scale, which is simple, as I said earlier. It's also recommended by our Geriatric Medicine Society. And so it's actually used for diagnosis of frailty in this study group. And very straightforward, simple look at the table here. For those who are frail, yes, they're unlikely to be able to ambulate, mobilize early within 72 hours. You can see that compared with a pre-fail, the frail patient. And of course, the higher chance of them have urinary tract infection, deep vein thrombosis, pulmonary embolism, and also most of them actually might need to have a longer stay in the hospital. And in this study showed that it's actually many of them stay more than 2 weeks, and also the higher incidence of in-hospital mortality and also 30 days mortality. And all this has been emphasized very clearly by Rajesh earlier, and he has given a very strong impact on all this frailty and the negative impact on patients with hip fractures following surgery. And this is an interesting study done by an anesthetist group by Vasu from India, and looking at the frailty and other risk factors affecting the outcome of patient hip fractures. And the primary aim of this paper was actually to assess the association of the modified frailty index with a 90-day mortality in patients age 65 and above who receive anesthesia for hip fracture surgery. And the secondary objective included the assessment of correlation of the waiting time for surgery after sustaining hip fractures and the 90-day mortality, and also the influence of a pre-existing medical condition on poor functional outcome of survivors. And this is the modified frailty index that I talk about. It is actually based on 19 of the potential 70 clinical deficits of the Canadian study of health and aging. And most of the study subjects actually have the MFI around 2, 3, and 4. And you can see that it's a clear association of MFI with a 90-day mortality, where MFI is less than 3. You can see that, all right, there's 0 mortality here compared with those above 3. This is a part that will be challenging, and I'm sure Rajesh will not be happy looking at this table here, because why? First, looking at the association of the 90-day mortality, all right, with the modified frailty index. I mentioned earlier, MFI less than 3 or equal to 3. None of them actually are 0 90-day mortality. And for those above 3, you have actually 23% of them actually 90-day mortality. But there's no association of waiting time in the days with associated with 90 days mortality, which actually different from meta-study result that particularly emphasized by Rajesh earlier. Most of the studies in the world that there is actually a close association between the waiting time for surgery after the hip fractures compared with mortality, either short-term or long-term mortality. So there's another one on the comorbid condition, and dementia is identified as one of the significant comorbid condition which actually causes functional disturbances for this group of patients as well. So this paper actually recommends from the anesthetic group. This is very important because surgeon, we always work closely with anesthetists and the geriatrician and the physician. So the anesthetics group actually recommend here and emphasize the point that there should be implementation of multidisciplinary hip fracture management group, including orthogeriatrician, and the standard care pattern or pathway for this special group of vulnerable patients. And standardization is actually very important. That reduces the care variability and improve patient outcome, including the measurement of hip fractures. So the introduction of national standards in anesthesia care for hip fractures in India can actually coherently be expected to have a similar benefit. It's something that being emphasized even by the anesthesia group. And they also highlighted the ASA score alone cannot predict the post-op outcome in elderly frail patient. And there's a need to develop and improve the available tool for frailty screening in pre-operative assessment. When you look at Manju Krishnan's paper from Cardiff, UK, and that actually Manju Krishnan stratified their study subject of 178 of them into 3 groups, where it's a low frailty group where FI is less than 0.25, and the intermediate group 0.25 to 0.4, and also high frailty index group where FI is more than 0.4. And look at this. For these 3 group of subjects here, the ASA mean ASA grade is about same 2.8 plus here. But looking at the low frailty index group, and 80% of them actually return home by 30 days, and there's 0 30-day mortality and 0 inpatient mortality, comparing with those intermediate and also the high day frailty index. And of course, all of us agree that for those who actually have high day frailty index, there are longer hospital stay as well. So the key point from this Manju Krishnan paper is that it actually shows that FI or frailty index is significantly associated with adverse outcome after hip fractures, including mortality and length of hospital stay. There's a 30-day mortality of 17.2% for whole high frailty index patient, and 3.4% for intermediate, and for all those less than 0.25, and all of them successfully return to home. And patients with high frailty group stay in hospital 3 times as long as those in the low frailty group. So all of this paper just show you a few this is done in this region, and also one from Manju Krishnan. And that tells us that there's something not right in the way that when we manage an elderly patient or we call an older person with hip fractures. I should say, this geriatric patient, they're very vulnerable to a lot of complications and so on. Therefore, this so-called 3-pillar measurement for fragile fractures is not only applying for those 50s, 60s, it is particularly more important for those who are frail, older patient who has all the comorbidity and also disability. These 3 pillars consist of multidisciplinary care and rehab, as well as a secondary fracture prevention. When a patient 80 years old comes with hip fracture in the emergency department, if you have the FLS in the hospital, the whole FLS team will be mobilized. And you have a team approach. The emergency physician, orthopedic surgeon, even geriatrician and physician see the patient even at the casualty level. And the anesthetic have been informed that this hip fracture patient comes in, implant have been arranged, and patient go to the ward within 24 hours possible, do the surgery as early as possible. And even when the patient gets admitted to the ward, the rehab team, dietitian, and all the other related party in the FLS team will be mobilized, as I say. Very important, providing acute care, reduce pain, and reduce the agony of fractured hip, and also what Rajesh mentioned, that all the physiological changes from the fractured hip itself. of course, an optimized medical condition. We cannot normalize them, but optimize them to reduce risk as best possible. Early surgery and also immediate post-op care. Very important, rehab is not only started after surgery, after fracture fixation. In fact, with the patient, while they're waiting for surgery in the ward, even they put a traction on the patient, rehab should have been started. The rehab comes to see the patient, start teaching the patient what you expect after surgery, and also have to start strengthening exercise upper limb, and also strengthening exercise of the other limb, and also breathing exercise and so on, prevent pressure sore. All these are pre-operative rehabilitation, and of course, post-operatively, we fix the fracture well. As a surgeon, we allow them to have immediate mobilization, ambulation, early weight bearing, strengthening exercises, coordination exercise, and not to forget fall risk assessment. So all these are meant to provide the best functional recovery for all these patients who call themselves old and frail. And of course, the third pillar, secondary fracture prevention. We know fracture will get fractured. We know many of them, they fracture one hip, they might even fracture the second hip within the first year. Why? They fall. Not only osteoporosis not being treated, they fall. So it's important to treat osteoporosis and treat the sarcopenia and have a successful, important, good fracture liaison service at the hospital. When we deal with an elderly older patient with hip fracture itself affects this group of people. And you can see that all the grannies, grandpa, and come to the hospital with fractures, and they're frail, and all this combined and compounding on each other, and that will actually tip them down. That's why they die. That's why they have very poor functional outcome after surgery. What's the point after surgery and it actually looks perfect, but the patient is actually on bed, on chair all the time? So frailty has been shown to predict adverse outcome in older surgical patients, no doubt about that. And compared with the low frailty levels, higher degrees of frailty leads to greater risk during the post-op period. There are more post-op complications, longer length of stay, early rehabilitation, and also greater morbidity and mortality. What we want to do for all these patients, even though they call themselves frail and old, we want to bring them back to the best functional status possible so that they say, I can still take care of myself with the hip fractures. With that, thank you very much.
Thank you, Dr. J.K. Lee. It was a wonderful presentation. In fact, trying to identify patients who are frail, not just by aging them or having a physiological age, just to classify them into frail and pre-frail and in normal condition is so important for us, especially the outcomes. So we have one question for you. I think you explained it to us that do you see that in a 6-month post-mortality in fracture neck, do you see frail patients, the mortality rates are higher in them?
Yes. I think that's a fact. I think in many places, particularly in those more the suburb area or the smaller setup, smaller place, because in our Asian culture, I don't know whether that applies to many other countries, this Asia Pacific as well. Many of them have hip fractures. And then when they get discharged, even though they have 10 children, and none of them bring her home, they actually send her to the nursing home because they say there's no time to take care of elderly. And a lot of all these patients even come back within 2 weeks, within a month, with bad pressure sore, sepsis, fever, pneumonia, all those things. They even die for all this. So that's why it's true that many of them, within the first 6 months, many of them even get readmitted because of all this complication, because of poor nursing care after surgery.
So you do recommend a comprehensive geriatric care as compared to just the standard orthopedic care. That's what you, I think, I
will encourage or actually suggest to have a proper orthogeriatric. Now, the problem is that there are not many geriatricians in many countries in the region. So like in Malaysia, we only have about 50 geriatricians for 33 million people. So it's impossible to have geriatrician in the practice in many hospitals. So we promote orthogeriatric care, but with a geriatrician, at the same time, orthogeriatric care without geriatrician. So we had to escalate the physician, anesthetist, a whole team to actually learn and to be interested in orthogeriatric care for this group of patients, even though we do not have a geriatrician at the hospital. So there are two different aspects.
I have two more questions. First question is, so once we identify that the patient is frail, so does our management of the fracture or the osteoporosis changes from the pre-frail and other patients? And the second part is, what is the importance of cognitive assessment in these patients? This is more of a physical assessment of the frailty. So there's also cognitive frailty in patients.
Yeah, I think the wrong feeling is that the older patient not worth spending time doing all this assessment, treatment, all this. That's actually very bad. In fact, a lot of family members have that kind of feeling. My mom's, don't do anything, just relieve the pain, move around, that's it. That's not right. In fact, the frail patient deserve more attention. They deserve more love and more care, and more tender loving care. In terms of the surgery itself, we actually optimize them, fix the fracture, move them up, let them walk, let them stand. And also, they also know that they actually had high risk of fall and further fractures. So assess the fall risk and improve the muscle function and coordination, balancing, and so on. And not to forget, a 90 years old frail patient doesn't mean she does not deserve anti-osteoporosis medicine. Not at all. They actually deserve all these things. They have actually and should enjoy the equal right and equal treatment, even though comparing with a non-frail patient. They should actually have more tender loving care and more intervention, in fact. And cognitive function, of course, is very important. I think many elderly patients, they do the delirium, post-op, and so on, and a lot of them have functional issue where they cannot get along with family, they cannot get along with carer, and carer say they don't know what happened with them. They don't study after surgery, the poor bad cognitive function, delirium, so on. They don't know how to handle them. That's very important part of geriatric assessment. That's why very important promoting orthogeriatric care. It's definitely very important to assess it.
Thank you for the answers. I think it's a very, very important and very interesting topic, because we are seeing a lot of people in the older age group, and as you said you come under frail, so we all are going to end up being frail. We're going to live longer, hopefully. So we'll get into the frail category, and then it's important to know and manage it in a different way. Thank you so much, sir. Now we move on to our last, but the most important talk. Our president, Dr. Marinis, please can you just enlighten us about the role of registry and how it has impacted the outcome in the osteoporotic hip fractures. So to you.
Just a little technical glitch. Thank you very much. I think all the talks today were wonderful, and this talk will hopefully complement all the previous talks. And it's about really measuring and trying to figure out why the registries are required, and really some surprises that we found with the registry data, and a little bit about how the registries were developed. So, when someone at 75 or 85 or even 95 presents, or anyone presents with a hip fracture, you would think that in any system or in any region, they should get very similar care. And one of the options here is a hip replacement, and we may be able to discuss the ins and outs of hip replacement in this particular age. But it would be on personal data. And then sometimes we need some more stronger data in order to be able to provide some support for our programs. Years ago, and this is some data from the 1st of July 2000 to the 30th of June 2011, and it looked at the hospitals in one of the states in Australia named New South Wales, and it looked at the hip fracture procedures commenced within 2 days of arriving in the hospital. And you can see the variability that JK and Rajesh alluded to in terms of the decision-making as to when a patient would get to the operating room. And that's a fairly significant rate that goes anywhere from 30% to 85% of the patients going to theatre within 48 hours. And then when you looked at survivorship, there was also variability in survivorship with patients that were standardized according to their age and gender and comorbidities. And this is a funnel plot. So in the same time frame around 2009 to 2011, what we can see is that there is a spread. Ideally, what we'd like the hospitals to be very similar in terms of the mean, which is the average, which is the black line in the middle of the funnel plot. But there are hospitals that set outside as outliers. And when you have data like that, it's really important to appreciate the fact that not all our hospitals and not all our surgeons are providing similar care. And at the time, there was a high mortality rate. There was about a 7% rate of dying in the hospital. And we knew at that time, or we were appreciating that mortality rates increase with time awaiting surgery. Now, around that time, the NICE guidelines, the National Institute of Clinical Excellence guidelines came across. And this is one of the drives that started in terms of hip fracture registries occurring and some standards occurring and some quality standards being accepted, and hospital teams and orthogeriatric teams working together in order to try and facilitate improvements in outcome in patients with hip fractures. And they found that in the United Kingdom, and we borrowed a lot of our modelling from the United Kingdom here in Australia between 2012 and 2017, there were a number of reorganisations within the system. One was the collection of data, and one was some financial incentives to provide best care. But that led to improved flow of patients, more consultant-led care, increased consultant-led care in older trauma, and better clinical care on the whole. And this led to the registry in Australia providing the initial impetus to develop a set of quality standards. And there was an analysis of the standards across the world, looking at their scope and purpose all the way to their independence. And that included the National Institute of Clinical Excellence guidelines. And then a scientific approach to develop a set of quality standards so that most surgeons could then collect the data, but also understand the data in terms of best practice. And then the hip fracture guidelines came across in 2014. Then there was an acceptance by them in 2016. And this was a very important part when a nation has a national approach. And this Australian Commission on Safety and Quality in Healthcare adopted the clinical care standards, and they're very similar standards. In fact, they're the same standards in Australia and New Zealand. So it's a bipartisan approach to the management of these issues. Now, we knew this was going to be important because when the World Health Organization takes a global view and looks at all the literature between 2013 and 2017, there was a worldwide reduction in mortality at 1 year post-hip fracture compared with previous research. And there was going to be a lot of benefit with the various national registries and the collaborations. And that's another important positive of having a hip fracture registry, in that there can be collaborations globally, but also regionally to compare approaches and share learnings. And this has been covered by Rajesh and JK. There are a lot of benefits to operating early, including lower VTE, lower death rates, and hopefully better long-term functional status. And this led to a whole lot of reports that came out, and I'll share some of the data in 2021, looking at how Australia's journey to improving some of its care for patients with fractured hips progressed. These were the quality standards, and they involved assessment of care or presentation, pain management. The orthogeriatric model of care we thought was very important, and that's a very important contributor to patient wellbeing and outcome. The timing of the surgery, the mobilisation, and we felt that early mobilisation was important. Minimising the risk of another fracture, just borrowing on JK's talk, was very important. And transition from hospital care was also an important statement in how that was done. This is the 2020 snapshot. You know, always the 2021 report or report the previous year's worth. And there are 86 hospitals in Australia and New Zealand contributing with 14,816 records. That's not too bad. And we'll go through some of the elements. You know, 67% had a preoperative assessment of cognition for one of the people that asked earlier why that was important. Now, what's happened over a few years? If you look at this graph, this is figure 36 from the report, and it looks at the mean between August 17, which is the top yellow line, 18, the second one, 19, the third one, and 20, which is the fourth one. And we can see that as we've measured and as we've improved flow through the hospitals, we've decreased the average length of stay in the emergency department, and we'll continue to do that. At the moment, it sits somewhere just over 6 hours, and we think it's important to try and get that down even further if we may. I think cognitive assessment, and JK touched upon it as well, I think it's very important because it's one of the determinants or the measures is what the ultimate disposition of the patient will be from the hospital and what the likely outcome will be. And so it's very important for it to be measured. We can see here that with the focus of the registry, there's been an increase in the number of patients that have been assessed for their cognitive state, but it's still not perfect. We can see that in 2018, which is the top graph, if you look at the yellow lines, that's assessed and normal. If you look at the light blue lines, that's assessed and abnormal. And if you look at the blue lines, that's not assessed. And we can see that there's been a move in terms of normal or assessed to be from about 50% to 73%. And we're working towards improving that further because we think that's a very important part, an important measure of care, as we've heard in a number of the talks today. I think pain relief is very important. You know, sometimes our elderly patients are unfortunately a little neglected in the emergency departments as there are other key priorities that turn up, you know, the person with the heart attack, the younger person with the fractured limb. And we can see here with the pain pathways, who had a pain pathway in Australia and New Zealand for patients with fractured neck of femurs. And we can see on the graph from 2013 all the way across to 2020, which is on the right, there's been an increase in the number of institutions in Australia. In Australia, it's gone from about 68% to 85%. So we can see that the registry and the reporting and the transparency and perhaps the accountability and people reflecting on the importance of this is changing practice in the ED. We think that nerve blocks are very important, and you probably assume that everyone has a nerve block in the emergency department. Here we can look at the nerve blocks by country and by state. Again, we can see in terms of the summary figures at the top, that is 2017, and we go down 2018, 2019, and 2020. The yellow lines are both before the OT and in the OT. And you can see the light blue line is nerve block administered before arriving in the OT. So we can see if you look through that data that in 2017, about 65% were getting a nerve block before arriving in the OT. And it was only up to 83, 84% in 2020. And we're trying to work on improving that. And sometimes that's related to process. Sometimes that's related to the ability to record the fact that they've had a nerve block. But I think a nerve block is very important when it's managing pain within the ED in terms of providing our patients with dignity, respect, and care. This is orthogeriatric care, and we can see here that, you know, 1 and 2 is really that regular orthogeriatric care that all of us would ideally like to have. And we can see that 1 is yellow and 2 is the light blue. And we can see from 2013 to 2020, there's been an increase in the orthogeriatricians involved in the care from about sort of 43% in 2013 to almost 60% in 2020 on a regular basis. And I think that's very important in terms of the rapid assessment, early management of issues, and the ongoing continuity of care in the post-operative period for rehabilitation and disposition of the patient. And we're working towards an even greater adoption of the orthogeriatric models across Australia. Surgery within 48 hours, and this is something that probably interests a lot of us. And we can see that from 2017 to 2020, yellow is surgery within 48 hours, and there's been a gradual increase, but perhaps not as substantial as we would have thought, because, you know, when I sort of saw the data in 2016, thought, oh, everyone will be going to theatre within 48 hours. But then when we look at it, it doesn't quite happen. And when we think about why it doesn't happen, the registry can allow you to delve into some of that. And if we look at the yellow lines, that is 2017 again to 2020, one of the issues is a delay due to theatre availability. And that is very much a reversible factor that can be changed. Here you can see a summary graph. This is a pie chart. And you can see the delay due to theatre availability is about 35%. And that's probably what probably the administrators would think now. That's probably unacceptable, because these patients then stay around for an extra day or two, perhaps, not being able to get to theatre. Now, what Sonali can also see is due to anticoagulation issues, about 16%. So I think that's another factor that we can deal with as we move forward. Now, the provision of individualised care, and we've been alluding to it a little bit, and Jake here alluded to it with his frailty index, but part of it is also the provision of discharge information when the patients go home, and part of it's related to the bisphosphonate treatment that Joyce discussed. And we can see that from 2013 to 2020, the proportion of hospitals that provided individualised information increased. But I would say it's been slow. Even the optimist in me would say it's been slow, because it's gone up from about 20% in 13 to about 55% in 2020. And for the person, and I think it was a good question in terms of why you would want to start the bisphosphonates immediately or very early in the piece, it's because a lot of these things aren't a priority once the surgery is done. Quite often the surgery is done, it's someone else's issue, and people then neglect, forget, and are not as mindful about the issues of individualised care, the management of bone health, and they're very important parts, both for the family, the patient, and the system. When you look at mortality, and I won't spend too much time on this, but the mortality has slowly decreased, but not so much. It was 7.6% in 2016, and that was about similar in 2020. And that's the adjusted mortality. The funnel plots have been pretty good more recently. This is 2018 to 2020. So we can see that by measuring hospitals, improving processes, and making people accountable, but also mindful of what the quality standards are, we can improve mortality. And perhaps getting some of the sicker patients to theatre earlier is also an important part of this. So, and it is important, and I won't delve too much on this because it's already been covered, but the, you know, in the UK National Hip Fracture database, which is a more mature database than Australia, the 30-day mortality fell from 10.9 to 8.5%, and there was an annual relative reduction in the adjusted 30-day mortality, which is important in terms of early mortality related to the injury and the treatment. And it also found that in the more senior patients, and this will be interesting to see whether it comes out of the Australian registry down the track, that the mortality in the older patients was even more influenced by delays to theatre. So I think a pragmatic approach is really important to try and get these patients to theatre nice and early, because, you know, age, gender, ASA were all independent predictors, and timing to surgery was also an independent predictor of survivability. Now, this is one of the elements that I think is important, and we need to sort of think about it and try and work within our systems to improve. This is bisphosphonates, and the yellow are the proportion of patients that are on bone protection medication or bisphosphonates at the time of discharge. And we can see that the yellow lines, there's 2017, 18, 19, and 20 again, and the yellow lines are bisphosphonates. The light blue lines are calcium and vitamin D only. And here we can see that there's a lot more work to do. At least there is some bone protection with calcium and vitamin D, but perhaps not enough. And the key factor to this would be the follow-up and whether the follow-up's done in terms of following up these patients with a fracture liaison service. Now, fracture liaison services, I think, are very important. And for those that don't have them, and I think here in the Asia-Pacific region, everyone's been working very hard behind the scenes to ensure that there are fracture liaison services in place. But they're very cost-effective. They're very cost-effective when you compare a care with a fracture liaison service as compared to care without a fracture liaison service. And in terms of fracture prevention, we're talking about bone protection, and this is where fracture liaison services may come in and ensure that there's fracture prevention. This is a study from America using their Medicare data, and the modelling showed that the reduction of fractures was about 5% over 5 years in patients with fractured neck of femurs who are on bone protection medication. So that's a lot of reduction, right? That's like 30,000 fractures per million patients. The cost saving, when you look at it as $418 over the lifetime of a patient, seems small. But when you look at it as a system of $418 million in 1 million patients, then it starts becoming really clear in terms of why we need to be doing some of these things, not only preventing fractures, improving the quality of life, whatever years they have left, but there are also significant cost savings to the system. And we can see right at the end there, better quality of life when it's measured. Now, the registry also allows us to benchmark our hospitals, and this is quite good. It's a nice, transparent process. The greens mean that you're doing well on each of the standards. The yellow means that you're doing okay. The red means that you haven't really met the standard, and the hospitals are identified actually in Australia. So the public hospitals and the private hospitals can see how they're doing. But what I'd like to, when you look at the outlier analysis, that was fairly green and yellow, the previous one. But when we look at this, you can see that, the first column is 1A, the second column is 2A, the third column is 7A. 7A is evidence of local arrangements for the development of an individualised care plan at discharge for hip fracture patients, right? So that's important, and we can see that most of the hospitals are falling down on this particular indicator. So, I think that we can do better with that as well, and we're using that to try and improve communication in our hospitals in Australia. And not only that, but the patients are now jumping on the bandwagon. The patients are not so happy. The aged care, the national seniors organisations are saying that our hip fracture care, perhaps it's not all it's cracked up to be. They would like us to do better. They would like us to meet these standards. They would like to provide them with the care they think they deserve and to improve their lives. And not only that, but the hospital systems are becoming involved. And here in Victoria, we have BAHI and the Safer Care Victoria. This is the Department of Health in Victoria. And they're now realising that better data access is also improving hip fracture care. So in conclusion, I think the registry brings with it a degree of transparency. It also brings with it education in terms of best practice models. It allows us to benchmark our practices with the outlier analysis. It allows patients and their relatives to advocate for better care. And it allows the government to make sure that we are doing the right thing and they are funding the appropriate resources for us to look after patients with fractured neck of femurs. Thank you very much.
Sorry. Thank you so much, Professor Marinis, for your great talk and make us clear in details about how important of hip registry that such in my country we are trying to develop it better about registry. So we have a few interesting questions from the audience to you. First is, are there any specific hip registry for orthogeriatric patients which is analyze the different races which have different outcomes?
I think there's a couple of answers to this. So most people that set up their registries set up the registries for particular questions, right? And I think that the people that are Sorry, I think the host muted me, so I apologise to everyone. So the people that are now starting their hip fracture registries, because this is becoming a topic of interest and discussion, are including some of these elements in the new fracture registry. So this may be data that becomes relevant down the track when looking at the demographics, particularly related to ethnicity and the racial background of patients. At the moment, I think the Australian and New Zealand Hip Fracture Registry has shared some tools with the Asia Pacific Orthopaedic Association and also with the Fragility Service. And I think the APOA is getting its mind around the concept and how the hip fracture registry may run in the Asia Pacific region. And perhaps, we have the president of that committee, or one of the presidents of the committee here related to the osteoporotic element, J.K. Lee. He may want to comment on that as well.
Thanks, Marinis. Actually, up to April 2021, there's only 18 countries that have a hip fracture registry. It's a lot of work to do. And in the first place is that the orthopedic community like us, and we had convinced ourselves that we had to buy the idea that registries is very important. Many of us still feel that, registry is not important. It can be an audit sort of thing for us, for my performance and so on. But in fact, we need to change the mindset for all our colleagues. Registry is very important. It actually helps us to do all the data collections and so on, look at the performance and how to improve ourselves in the future and so on. So it would be ideal that all countries have their own hip fracture registry. In fact, the Asia Pacific Fragility Fracture Alliance that Marinis know very well, we actually published a hip fracture registry toolbox, which is actually online, available online in our website, APFFA, and also have shared that with all our APOA council members and our members as well.
I think it's very important, JK. I think that last element is that people have to move away from thinking it's an audit of their personal behaviour and really moving to it's a systems-based analysis of what is best for our patients. The registry, once the data is shared, we don't have any issues. We really do not have patients coming and saying, your hospital's not particularly good at doing this. It's more ourselves talking to each other and saying, well, how do you guys do that at your hospital and we can't do it at ours? Because, we may have similar resources, but you manage to get a little bit more out of those resources and you can manage to hit that quality standard. And the quality standards, especially once we start providing our patients with individualized notification, and that should probably start at the time of admission, we need to allow and share our knowledge with our patients and their relatives so they understand what they may expect. Because at the moment, they have no idea what they expect, and that touches on that point that JK mentioned before about frailty. They're too old, you shouldn't do anything. It's not about that at all. It's like, this is our data. So part of the consenting process for any admission of a patient with a fractured hip to a hospital should be like, what should be the expectations based on the global data? And then the family can make their decisions accordingly, and the hospital doctors, of course. So that was a good question, Science. Thank you for your question.
Okay, and for the next question is, why are results often drastically different in various registries?
Yeah, I'm not sure if they're drastically different, but I think what we're doing now is it's a journey and it's a pathway. So depending on where you start on that journey, you may start at a point that's a little earlier or a little bit later. There may be challenges between the individual networks. One of the things Rajesh mentioned earlier was that the networks, and Joyce mentioned as well, that there are some limitations in some of the networks, that it may not have the same services. JK mentioned there are only very few geriatricians in Malaysia, and all those elements impact on the outcome of the patient. We may not realise that they're important determinants, but then when you sit back and look at the data, and I really suggest that whoever's interested in this goes to that data set when the Australian Hip Fracture Registry was, I can talk about it because I know it's online, and has a look at the data of how it was analysed, what their depth process was, and how they came to the conclusions of the different quality standards. And then you can start getting your head around what the differences are between the countries it was set up in and other countries in the region and globally. And if the elements are different, that creates a heterogeneity, and that creates, I think, the variations in the outcome. As we move forward, and hopefully we move towards providing similar care, so we can minimise what JK described as the variability in the system, a similar care with a similar quality of care, then hopefully as we move forward, we'll have similar results in the various hip fracture registries. The other thing that sometimes I think when you look at a registry is you think all registries are exactly the same, and they're not, because sometimes they're measuring, and I know they're measuring slightly different aspects of orthogeriatric care, slightly different aspects of hip fracture care. So we have to compare like with like when we're looking at the registry. So when you look at registry data, you have to go back and think about, well, where is this data generated? What is the care that's provided? And what are the elements that are different between each individual registry data sets? And that's where I think the global comparisons will become relevant, because just like we're talking between our hospitals in Australia and saying, hey, how did you do that? How did you hit that standard with the services you have? When we talk between the registries, it'll be like, how do you guys do that at a national level, at a systems level? And what things do we need to put in place? So in the UK, we know that there's a financial incentive, and there is the orthopaedics was very involved in it, as was the NHS. And Keith Willett was a very big proponent of it many years ago. And he incentivized the system to provide funding to the hospitals when they provided every element of care. So to get the full funding package, you had to hit every single standard along the way. And there is nothing more important for everyone to reflect upon, and not only their care, but how you meet that care. And then when the CEOs or the authorities in that particular hospital think about how they're remunerated for that care, when we align local care with the governance at hospital level and the governance at national level, that's when we really have a more harmonious system. I think you've been muted. Well, science, that's terrific. I think we've covered most of the questions. Is that correct?
Yeah, it's not on a question still right now. Right. I think we have just a couple of minutes to end of this meeting. So maybe we move to panel discussion. So any speakers to have the comments for this meeting before ending?
Science, allow me to say something, Science. Marinis, when you actually have a discussion just now, I can see from your eyes full of passion when you talk about registry, talk about all this fracture liaison service. You can see the passion actually from your eyes, okay? And this kind of passion is very contagious. And I hope that this kind of passion spread to all our members of APOA. You can actually follow your way and your platform to actually allow us to create a hip fracture registry and also all these orthogeriatric cares for all our patients, for all our members of APOA. Marinis, I respect that.
Thank you, JK. Yes, I think it's an important, I think we should work towards establishing them all through the Asia-Pacific region. Science, I may take this opportunity to thank everyone. I think we have about a minute left, probably, and I think it's been a very interesting and a very rewarding seminar. I think we've talked about things that sometimes as orthopaedic surgeons we think about, but perhaps we're committed to so many other aspects of our life that we don't have the opportunity to focus on the quality of care for all our patients, including what I would argue are some of the most vulnerable patients. who need to be respected because they, in their own way, have contributed for many, many years to the point where they became vulnerable and had their fractured hip. So I'd really like to thank everyone that's presented today. I'd like to thank Joyce Koh Bee, Rajesh Malhotra, Sonali Pande, Joyce Lee, and I'd like to really thank our moderators. I think you did a terrific job. You've kept us all on time. To Bedri Karamay Loglu, Saraswati Viswanathan, and Science Metadi Logul. I'd also like to thank the societies that work closely in this area. I'd like to acknowledge both the Research Society and also our Fragility Society, because I think they are going to be providing the solutions together with us collaboratively to try and resolve some of these issues. And we had both their presidents here today, which I'm thrilled about, and shows a very collaborative APOA approach. I'd like to thank the APOA for their support of this webinar series. And of course, I'd like to thank Jamal. Jamal, who is our second vice president at the APOA. He does a mountain of work behind the scenes to help organise these seminars and to make them run smoothly. So Jamal, would you like to say a few words before we close?
We've come to the end, so bye-bye.
All right, very good, everyone. Have a lovely evening. Enjoy.
Bye. Bye.
Thank you.
Thank you.
Bye. Thank you.
Bye.
Thank you.
We are offer now, ma'am. We are offer. Hello? Ma'am, we are offer. Meenakshi, ma'am. Sir, are you ready?
Hello.
Sir, are you ready?
Bijal, you can stop the meeting, not an issue.
Okay.
Bijal, am I audible?
Hello. Yes, ma'am. Yes, ma'am. Yes, ma'am. I'm on another webcast. I'll just end the meeting.
Yeah, you can end the meeting.
Yeah, thank you.
Thank you.